Good evening, respected judges. I'll be presenting a series of 40 cases of Rhino orbital mucormycosis from a tertiary care hospital in New Delhi, with a particular reference to epidemiological, radiological, and microbiological data. I will also be highlighting the factors in decision making for orbital exentration. Now, our study was a retrospective analysis of histopathological, microbiologically proven rhino-orbital mucormycosis cases that presented to us in a period from January 2009 to 2019. 33 out of 40 cases were given a combination of medical therapy of liposomal M4B with posaconazole, whereas 7 out of 40 cases received liposomal M4B alone. Also, all the patients underwent functional endoscopic sinus surgery, that is FES. Now, the decision making for orbital exentration was based on number one, the aggression of disease, the underlying predisposing factors, and initial response to medical therapy. The aggression of the disease was defined by the clinical presentation of the disease, microbiological evaluation, and further supported on by histopath and radiological findings. So, clinically, the patient presented to us with foul-smelling nasal crust, along with proptosis, chemosis, orbital congestion, and involvement of third, fourth, sixth cranial nerves that suggested superior orbital fissure syndrome. Now, if the patient had no perception of light with CRAO and corneal anesthesia, along with orbital fissure syndrome, denoted orbital apex involvement. Additional signs of facial numbness and facial anhidrosis, along with orbital apex syndrome, indicated cavernous sinus spread. Also, the nasal mucosal eschars seen on diagnostic nasal endoscopy fairly are diagnostic of mucormycosis. The diagnosis was confirmed by identification of aseptate hyphae on KOH wet mount and recovery of rhizopus later in the culture. The histopath showed the characteristic hyphae and angioinvasion supporting the aggression of disease. Radiology confirmed the disease extent. MRI axial view above shows the orbital apex involvement, and the image below reveals the extension into the cavernous sinus. So, orbital exentration was done in those cases when, along with the aforementioned clinical presentation, along with irreversibility or rapidly deteriorating underlying disease process, with no or minimal response to initial therapy with intravenous LM4B with posaconazole within first 48 hours. The relative contraindications to orbital exentration were the bilateral disease, extensive intracranial spread, and little chance of survival. Now, coming to the results, the average age of presentation in our study was 51 years with male preponderance. The most common predisposing factor in our study was uncontrolled diabetes mellitus that was seen in 36 out of 40 cases, followed by chronic steroid use. Intracranial extension was seen in 18 out of 40 cases. However, 22 out of 40 had rhino-orbital disease only. 25 out of 40 underwent functional endoscopic sinus surgery with orbital exentration. 15 out of 40 had FES alone. The follow-up period was 3 months, and a mortality rate of 12% was seen in cases who underwent FES with orbital exentration, compared to 60% for the patients who underwent FES alone. The overall mortality rate was 30%. So, based on our study, it can be concluded that, number one, uncontrolled diabetes mellitus with or without diabetic ketoacidosis is the most common predisposing factor. Number two, the early diagnosis of mucormycosis and irreversibility of underlying disease was associated with lower mortality. Number three, timely exentration in appropriate cases may help improve the survival rates. And finally, survival outcome was significantly better in patients managed with FES with orbital exentration. Coming to discussion, based on the data from Global Fungal Registry, malignancy is the predominant underlying condition for mucormycosis. In contrast, our study reports uncontrolled diabetes mellitus with or without DKA to be the predominant risk factor. Now, this is similar to the results of the other studies done in India, where diabetes mellitus continues to be the major underlying cause of rhino-orbital mucormycosis. In a retrozygote study, a lower mortality rate has been reported in patients with diabetes with DKA, where the underlying disease process, that is, the blood glucose level is possible, as compared to other risk factors like malignancy or solid organ transplant, where the reversal of immunosuppression and metabolic derangement is difficult. In our retrospective analysis, the mortality rate at 3 months follow-up was 12% in cases who underwent FES with orbital exenteration, as compared to 60% in cases who underwent FES alone. So, our study emphasizes the significance of orbital exenteration in reducing the fungal load and achieving the local control of the disease in cases with presence or threatened intracranial spread. Now, coming to the lacunae, the main drawback of our study is that it is a retrospective study, and no emphasis has been made on the debridement of pterygopalatine fossa, which is the reservoir of infection. The recurrence rate was not, evaluation was not carried out. Diabetic ketoacidosis effect on the survival rate was not documented, and no definite protocol has been made for management of different stages of orbital involvement. Finally, it is not a control study because it is ethically and morally not possible to carry out a control study in such a case. So we are planning a prospective study pertaining to the variables in the lacunae with a larger sample size. Thank you.
You said one of the contraindications of doing the exenteration was the bilateral cases. So why in bilateral cases you don't want to do exenteration? Because the life is important?
So, but it has been reported that when the presentation is bilateral, there is the chances of survival are very less.
No, but
for the patient.
spray to the orbit, spray to the cranial cavity might be restricted if you do a bilateral at the same time.
So usually the bilateral presentation occurs, it spreads from one orbit through the cavernous sinus to the other orbit. This is how, because it routes through the nasal mucosa, then it goes into the, invades the orbit, and then through cavernous sinus, it infects the other orbit. So that is how the bilateral, so cavernous sinus has already been involved.
Bilateral has to be differentiated from cavernous sinus thrombosis on the contralateral side, right?
Yes.
But did you encounter any bilateral cases? You said you did not do, but did you have any such occasion?
So we had,
You had, okay.
yeah,
All right.
one patient was a bilateral presentation.
Generally, 72 hours is taken as the cutoff for declaring medical management has failed. Why did you choose 48 hours?
So this is various time limit. The time for orbital exenteration has been in various studies have been reported. Like in one study it is 72 hours. In another they take 1 week as a cutoff. So, but what we saw from the retrospective analysis that most of the studies are highlighting that it's not just one thing, sir, that not only the 48 hours, it's about the underlying disease process also. If it is reversible and the condition and the disease is not that aggressive, then 48 hours was the time that we decided for our study.
What was the mean time for exenteration from the time you started antifungals in your study?
So it was around 24 to 30.
So there was a variation, right?
There was a little variation.
Yeah,
sir.
because there's a reported case series. It's not a very large sample size that has shown that patients who had general anesthesia contraindications where orbital exenteration could not be performed for that reason, and who are on medical therapy who are initially worsening actually spontaneously recovered, in the sense that they had a limited form of residual disease, right? So there is an argument to wait a little longer than 48 hours.
So it generally depends on the
I understand
physician's
that. I understand
decision.
that. So possibly in your retrospective study you can look at it.
Yes, sir.
Thank you so much. Very good presentation.
Thank you.
The next one is Dr.